Hi, Dr. Hofmeister. How are you?
Hey, Jack. How are you?
I'm doing well. I wanted to ask you questions specifically about how you treat your patients with the thought of helping patients who are listening to this conversation know what to ask their doctors. So with all the good information you provided about the high-risk smoldering myeloma patients, how do you personally assess whether or not to treat them today? And if you determine treatment is warranted, what treatments do you select? And by the way, does insurance cover that?
So for the high-risk smoldering patient population, I frequently discuss the current Mayo Clinic criteria of 20-20 to specify those patients who are high risk to develop multiple myeloma, those patients who have greater than 2 grams monoclonal protein, greater than 20% plasma cells, greater than 20 serum free light chain ratio. Those patients are likely to benefit from lenalidomide as described by Dr. Loniel, and I found that data very reasonable, very compelling in those patients who have high-risk disease. I think being on lenalidomide makes good sense. And as for does everyone approve that? I don't think so. And but the ICD-10 code for smoldering myeloma and the ICD-10 code for myeloma are exactly the same. So some people don't even pay much attention to it.
Okay.
I think treatment in those high-risk patients is very reasonable, but again, it's not like my clinic is blowing up with high-risk smoldering myeloma. My clinic is filled with people who have fractures, anemia, and kidney failure from active disease, and that's what I spend most of my time with.
Got it. So my next question is, when being treated for myeloma, how often should patients get imaging scans? Do you prefer MRI or PET-CT or both? And by the way, it should also be included for any kind of MRD analysis, right?
Yes, I think that's very reasonable. I think imaging in patients who have oligosecretory or non-secretory disease is one group. Those patients get a lot more imaging, a lot more regularly, because you're using it to assess the status of their myeloma. So every 2 months, they may be getting CTs or MRIs. And so that's a separate group. For your average myeloma patient that has plenty of protein to measure, I use imaging really if I have questions. If I want to know if their smoldering myeloma it has evidence of myeloma bone disease, etc. I do not do PET scans to evaluate for if somebody has presence or absence of myeloma bone disease, as I have seen too many patients who've had lytic bone disease that wasn't picked up on a PET. And that drives me crazy. And because, many radiologists, they'll just talk about the areas that were PET positive, and they'll ignore the areas that are PET negative. So while it's true that most of the bone disease for 90% of the myeloma patients should be PET positive, 10% are not going to be PET positive, and then there's a proportion of patients who have some lesions that are PET positive and some are negative for whatever reason. So I don't like using PET CTs to assess the status or if a patient has myeloma bone disease, and tend to use MRIs of the spine and pelvis to try to figure that out. I use MRD analysis on clinical trial and rarely use it in clinical practice, and use it primarily in clinical practice to figure out if somebody should stay on toxic maintenance therapy.
Thank you very much. And my last question, do you treat high-risk myeloma patients differently than standard risk, and if so, how?
Absolutely. In patients who are newly diagnosed, our current practice my current practice is to give patients with high-risk myeloma KRD because I can dose escalate the carfilzomib or the Kyprolis. For those patients with standard risk disease who are newly diagnosed, giving them daratumumab and RVD is a very reasonable kind of extrapolation based on data from Cassiopeia. And then at second, third, fourth line therapy, those patients with higher risk disease go under the mantra that it's the myeloma until proven otherwise. So they're followed differently, the labs are different, and my prejudice is different. I always think that any complaint in a patient with high-risk myeloma is somehow related to the myeloma. I just have to figure it out. Whereas those patients with standard risk disease, I'm willing to accept that some ache may not be related to the myeloma, and whereas those patients with high-risk disease, I'm not.
Thanks so much, Doctor. On to Cindy Chmielewski.
Hi. Good morning, Dr. Hofmeister. Thanks for taking time to answer our questions. I guess my first question is, can you explain to us what a CELMoD is? Is it any different from an IMiD? Is it going to be the new names for IMiDs? And a little bit about the new CELMoD IBER?
Yeah, I thought I might get this comment. So I think that CC220 and 92480 are two drugs that Celgene has recently created to help us treat patients with relapsed myeloma, and I am not 100% certain that this is really a whole new line of therapy or whether it's just significantly better, much the way that Pomalyst was significantly better than Revlimid. So I think that CC220 is clearly, is clinically and preclinically superior to Pomalyst, and it seems to go along a nice trend, which is as Revlimid goes to Pomalyst, you have more efficacy and less toxicity. As Pomalyst goes to iberdomide or CC220, it seems that you have improved efficacy and less toxicity. And that's a nice trend, and I'm hoping that continues.
Do you think it, and this is using your crystal ball, I guess, you were saying using the best treatment up front, if that trend continues, do you think that the CC220 might be the part of the induction therapy as opposed to Revlimid, or too early to tell, or? Right.
From a clinician perspective, right, as I'm here sitting with a patient, I want the patient to get the best therapy. And so, yeah, if I could have a magic wand, absolutely. That is likely to be the best, cereblon targeting agent we have. But is that likely to happen in the future? Probably not. I still have to go through Revlimid to get the Pomalyst. So I'm not really all that assured that I'm going to be able to use CC220 in the upfront setting, acknowledging, of course, that what just got reported was the first phase 1-2 trial of CC220 in the relapse refractory setting. It's a long road to get from there to upfront therapy.
Fair enough. Okay, you answered a lot of my questions about the MyDrug trial. So now I'm clear that it's basically the target audience is early relapsed high-risk multiple myeloma patients. What about those patients who are out of treatment options? Would having a test such as the next-generation sequencing test that may identify some of those target mutations and then trying those drugs be something that they should consider? Is that something that, I didn't realize until just recently that it wasn't for that group of patients, that it's for patients earlier in relapse.
Right. I mean, you point to an absolute area of need. Those patients who have been through, been there, done that. What do you have for me now, doc? That's what I spend 80% of my time doing. Those are the patients where we really want to have new and novel agents in the relapse setting to be able to assist them. And the number of patients of those patients who do some type of next generation sequencing via Foundation Medicine or other such tests, the number of them who've then gone on to get that novel agent and then get a response, I just feel like it's a very, very small number of people. And I kind of wish that everyone with relapse disease who's, at your second, at your third relapse, it would be great to try, if it's within reach, to get to a myeloma center to consider clinical trial therapy. And, I think part of the reason, we haven't cured myeloma is that we have, as physicians, not been able to offer enough patients clinical trial options. And so if you have a patient who is savvy to their myeloma, I'd much prefer them to consider going to a center with clinical trials rather than trying to figure out what to do with a KRAS mutation.
That sounds good. Yeah, those mutations that they're testing for, do you think there may be some myeloma-specific mutations out there that we haven't found yet? And because there hasn't been enough patients going through this next-generation sequencing? And
Absolutely.
Anything about that? Okay.
Absolutely. My colleagues here, two fabulous gene jockeys, Dr. Ben Barwick and Larry Boyce, they recently published a fabulous paper looking at a so-called IGL translocation that they found through a number of ways, but through validated thus far in the MMRF COMPASS study. And that's a translocation that seems to be very significant, it's suggestive now that these patients don't respond well to IMiD therapy, and you can't find that on a fish. It's just not going to happen. They don't have that. You're only going to find it on karyotype, and who finds anything on karyotype? Half the time karyotype doesn't grow, and you don't get any results in myeloma. It's a small number of patients. So I think that there are certainly many genetic abnormalities that have not been discovered, and that ideally we hope will be targetable, and that we can do better in those patients, because just ask anyone who has so-called standard risk disease and relapses early. Well, obviously they don't have standard risk disease, and we had no idea why. And I saw patients like that just yesterday in clinic who've done terribly, and I don't know why, and it drives me crazy. So I think there's much to learn.
Right, they're the clinically high-risk patients. They don't have the markers, but respond that way. Could you just, for the people that are listening in, explain what karyotyping is? Might be a term they're not familiar with.
Absolutely, my apologies. So normally a bone marrow biopsy, if you don't know anything about what a patient has, you'll first look to see what kind of cells are in there. That's the morphology. That's the pathologist looking at it. Many people, and I think if you don't have a diagnosis, you should send for flow cytometry, and that's looking for specific markers on the outer surface of the cells to see, oh yeah, I have B cells that is a clone of them, or T cells, or whatever that's in there. Flow cytometry makes good sense. Then you can take the aspirate, just throw it in a dish, and wait 24 hours and 48 hours and see what grows. and that's karyotype. They do that in newborns as part of newborn screening, and they do it on bone marrow biopsies. It is very difficult, or it's rare to get a positive karyotype, just your chromosomes, because you're visually just hoping that these myeloma cells survive outside of the bone marrow, and only 20% of myeloma cells do. And then there's FISH, which is actually staining the patient's bone marrow with fluorescent probes looking for specific mutations. And most of the time, bone marrow is sent for, morphology, flow. Sometimes they do karyotype, sometimes they do FISH, and it makes good sense, at least in a patient with an ongoing diagnosis of myeloma, to send FISH, a full panel of FISH, at least one point along the way, and karyotype is a way to look for genetic abnormalities that you didn't know would be there, but a very small number of patients have myeloma that's able to grow in a dish.
Okay.
So we have some questions sent in by our audience, Dr. Hofmeister. There are two questions on the 22-20 rule or criteria. The first one is, what is the 22-20 rule and to whom does this apply? And what is the difference between 2-20-20 criteria and 22-20 criteria? I'm so confused.
Right. My apologies. I'm not trying to flip the numbers. It's basically it's based on a Mayo Clinic retrospective for patients with smoldering myeloma, trying to find those patients who don't yet have a myeloma-defining event, which is greater than 60% plasma cells, serum free light chain ratio greater than 100, or greater than 1 focal lesion on MRI. So it's trying to look at those their retrospective panel of patients and then saying, wait a minute, we don't want to just find the people who have CRAB criteria. We also don't want to find those people with the so-called myeloma-defining events, the serum free light chain ratio greater than 100, etc. We're looking to see, is there a high-risk group of patients with smoldering myeloma, and they did find those and publish that. And really it's patients who have a monoclonal protein greater than 2 grams, those patients who have a serum free light chain ratio greater than 20, and those patients who have a greater than 20% plasma cells on bone marrow. So that's the rule, and I don't think it matters whether you call it 22-20 or 20-22. Either way, it's just flipping the numbers.
Okay. The next question is more better than less in treating high-risk smoldering myeloma?
That's a great question, and active clinical trials trying to answer that question. Just in this call, we talked about Dr. Loniel's ECOG trial looking at Revlimid versus observation. We also talked about Dr. Mateos' trial looking at KRD, autologous transplant, followed by KRD maintenance. Both of those were in patients who had smoldering myeloma, albeit slightly different groups of smoldering myeloma patients, but absolutely one of them is just a single drug and one is, 3 drugs, transplant and 3 drugs. And clearly we need to both look at response, we need to look at toxicities, we need to look at second primary malignancies, and ultimately an overall survival signal to help us find our way towards choosing the right patients to treat with the right drugs.
Thank you, Doctor. One last question before we wrap up. I think you already defined high-risk smoldering multiple myeloma, but we still have a question which says, what is the current accepted definition of high-risk smoldering multiple myeloma? So probably we could just stop with that.
So I think a very reasonable definition of high-risk smoldering myeloma is the greater than 2 grams monoclonal protein, serum free light chain ratio greater than 20, and 20% plasma cells or greater. I think that is a very reasonable definition of the high risks. I think where it gets super complicated is where somebody says, well, that's great, but I want to know what are the intermediate risks. And, and I'm in Spain, so I can use our fabulous flow cytometry techniques to find the greater than 95% abnormal plasma cells, versus no, I'm in Mayo Clinic. I can use other techniques to find intermediate and high risk. So I think the 20% plasma cells, the 2 grams of monoclonal protein, and the light chain ratio greater than 20 is probably a very reasonable way to get the patients who are high risk smoldering myeloma.